service travel and other things that took me away from my home desk and neurology VMR, but good to be back and see everyone. Some familiar neurology faces and a lot of new faces, which is awesome as well. I think somebody has a case I'm aware of. Yeah, Maria has a case. Amazing. So we'll need two people to discuss that case with Maria and myself. I see somebody is being encouraged to participate. Voluntold is the new term I've heard. Somebody is being voluntold to participate. You're welcome to, Andrea. You're not obliged. Okay, who would like to discuss this case with Maria and myself? We have a lot of new faces.
I can go.
Oh, fantastic, Andrea. All right. And one more discussant. Do we still do it that way? It's been a long time, two discussants. Yeah.
I believe Sridhara wants to discuss as well.
Yeah, I could do it.
Is that the case?
Absolutely.
Fantastic. All right, Maria, Sridhara, Andrea, fantastic, phenomenal. Would you like to introduce yourselves? Tell us where you're joining us from, and then we'll go ahead and get started. No one? Well, maybe I should introduce myself.
I was going to say I can go ahead. I've been on before. I'm really excited to come back. I'm coming from Jefferson. I'm one of the stroke neurologists.
Yes,
Philadelphia.
we've discussed before. Fantastic to have another neurologist here discussing cases together and teaching myself and everyone. Maria, Andrea.
Yeah, sure. I can go for a second. My name is Maria. I'm joining from Guatemala, and I'm very excited to bring this case to you. Me and Andrea are gonna be joining, like we're applying for neurology residency this year, so this is exciting.
Oh, fantastic. Another neurology applicant. Fantastic. Excited to, I knew about Maria and I'm extremely excited, and excited also to meet you, Andrea, and welcome you to the family.
Thank you so much. I think this is the second time I joined, so I am pretty new. I'm an IMG from Venezuela, but I'm currently in Colorado in the US doing a research fellow in white matter imaging. So I'm excited to be here.
Fantastic. We're excited to have you. And there's so many new people here. Maybe I should introduce myself since we're not just the regular crowd. I'm Aaron. I'm a general neurologist and neurohospitalist at UCSF, University of California in San Francisco. I work at the VA with Robbie and Jack and many of our other CP Solvers friends, and also at San Francisco General, and very involved in clinical care and teaching our extraordinary neurology residents. So Maria, would you like to tell us just the chief complaint, chief concern?
Yeah, I'm very excited for this one. A one word, as we usually do, is clumsiness.
Clumsiness. Okay. Andrea, what comes to mind when you hear clumsiness?
So when I hear clumsiness, I first want to understand what do they mean by that specifically? Is the patient having trouble walking? Are they having problem with orientation, with staying still in one place? Are they seeing things spinning? What specifically are they referring to with clumsiness?
Fantastic. And what sorts of things in your experience, or would you think that the patient could use clumsiness to describe as far as neurologic functions? You've alluded to some, but in your mind, when you're saying, what do you mean by clumsiness? Presumably you might have some functions in your mind, and the clumsiness by the patient could mean X, it could mean Y, it could mean Z. What are you thinking of?
I think some patients may refer to clumsiness as maybe their motor function is not as well as it used to be. Like they are not able to do certain tasks, like maybe they cannot keep things in their hand, or maybe they are not very accurate at drawing or at writing or at holding things. That's probably what most people I heard refer to clumsiness as.
Yeah, great. So you're saying someone might say clumsiness, but they may mean weakness, actually, that they can't use, they are not dexterous because of weakness or a loss of motor function. Yeah, what other things do you think of, Sridhara, when you hear clumsiness?
Yeah, the other thing that comes to mind is ataxia.
Yeah. Go ahead. Yeah.
Yeah, so clumsiness, the way I think about it is there is a disconnection between what you want to do, like what you're imagining the motor activity you want to do, and the final product. So it can be either weakness from corticospinal tracts, or it can be ataxia from spinocerebellar tracts, and that's connection. So that's kind of how I think about clumsiness when I hear that word.
Yeah, fantastic. So with any symptom, right, the patient will have their narrative, their way of describing it, and we have to decode that into things that we can then use to ask further questions. So yeah, I would agree. When I hear clumsiness as a neurologist, I think incoordination, and then I jump to cerebellum in my mind, but of course the patient may mean different things. So first, not all ataxia is cerebellar. That may become a point later. It can be sensory ataxia if there's impaired proprioception, but a patient may report the subjective experience of clumsiness if they're uncoordinated, which could be ataxia. They may report the sensation or the subjective experience of clumsiness if they're weak from motor problem, which could be anywhere from the brain all the way down through to the muscle. They also may report clumsiness if they're numb, if the hand is numb, if there's a sensory problem, because without getting the sensory feedback that we need to guide our actions, which the cerebellum uses, and maybe we'll get more into that depending on where this goes, the patient can also report clumsiness. So those are probably the three things I would think of as this weakness, numbness, or a sensory problem, or ataxia. And for example, just common things being common when patients have carpal tunnel syndrome, even if they don't actually have weakness from the numbness in the thumb and fingers, which we use so much, that's why we have this opposable thumb to be able to do so many interesting things with our hand. They may actually report that the hand is clumsy, and they are experiencing clumsiness. They're dropping things, but from a loss of sensation. So some of this is going to guide the initial history taking, right? The patient will say, I'm here because I'm clumsy. And you might say, well, tell me more about that. And they may elucidate that by telling you examples of dropping things, difficulty with buttoning their shirt or the zipper, or typing on their phone or something like this, but it still may not be clear. So then you might ask, does your hand feel weak, or does it feel strong? Or does your hand feel numb or tingly or prickly? Or have you noticed when you wash the dishes, do you feel any, are you able to feel the temperature to get at sensation? And then other questions to get at ataxia, whether there's imbalance with gait. And again, this is going to depend on whether this is in one hand or both feet or the entire body, et cetera. But I think initial branch point for clumsiness, we'd be wondering, is this motor, sensory, or cerebellar? Any other ways a patient might use clumsy to describe a function? Those are the three I would think of: motor, sensory, and coordination. Anything else?
I think someone mentioned in the chat dressing apraxia or other types of apraxia. That's a good point. Patients might just think that they have clumsiness doing those activities as well. That's a good point.
Yeah, could the patient have apraxia? It's interesting. What do patients say when they have apraxia? I'm not sure. I feel like apraxia is something we sort of end up discovering on exam. And does a patient tell you, what do they actually say? I don't know. What's your experience?
It's usually the spouse.
This usually the spouse is what I was going to say, yeah.
Or the partner that says, oh, they're clumsy getting dressed, or something like that. And then you're like, okay. And then
I see what you mean.
Testing, you see that.
I'm trying to think of the last case of apraxia I saw, and the patient was just saying the hand didn't work. They didn't say clumsy. They just said it's not working right. And they kept lifting it and saying, you see, it doesn't look, it's not working. And I thought, it looks like it's working. And it was working, actually. Motor sensation and coordination were intact, but then skilled learned actions were absent. That's apraxia. So interesting thought for apraxia as well, higher cognitive function as well. Okay, so with those in mind, we'll want to clarify, is this weakness, is this numbness, or is this incoordination through hearing more of the history? And of course, we'll want to know the time course, as well as the sudden onset and focal clumsiness, then Sridhara is going to get called and emergently as a stroke neurologist, right, to understand if this is stroke, if this is subacute or chronic, if it's the legs, the arms, etc. So let's hear some more history from Maria.
Okay, trying to keep up my poker face. So I'm just gonna jump right into the HPI. It's a 72-year-old female who reports over a 20-year-long history of difficulty walking. She initially noted she was clumsy and had frequent falls while she was walking normally. People would tell her, why are you tripping? And she would not know what to respond. This worsened particularly over the last 10 years as the difficulty walking has progressed to the point where initially she needed a cane and now she needs a wheelchair. She also reports feeling clumsy in her hands, especially while washing the dishes or dressing herself, and having difficulty in her speech, which started more recently in the last 5 years. During the last 5 years, she's also needed help in most activities of daily life, from showering, dressing, and eating. She does not report any sensory abnormalities or any difficulty swallowing.
Fantastic, Maria. Okay, Andrea, we have some more history here. What are you thinking now?
So the clumsiness, the balance problems, and the difficulty walking do make me think of a cerebellar disorder, and makes me think of something more degenerative given the chronic course, and that has been also getting worse over time. Now, I was a little bit confused about whether there is sensory abnormality or not. I think there's not. Okay, because I was also thinking maybe it could be like a peripheral neuropathy. Other than that, based on like possibility of weakness and the chronic course and progression, I also think of like a motor neuron disease, or like a muscular problem, like a muscular disorder. I would ask her if she has any, if she feels any pain in her muscles. And I would also think of going along with the progressive degenerative course. I would ask her more about how the symptoms started, if there was any trigger event, what happened in the past when it all started, because sometimes I know that some people, for example, with multiple sclerosis had one event in the past, but it progresses very differently over the course of time until they actually start getting worse. So yeah, I'm mostly thinking still on like cerebellar would be my first thought.
Yeah, excellent. So so much excellent neurology you just discussed with us. So let's highlight a few things here. So first, you flagged that this is a 20-year course of illness, so that suggests some type of degenerative process, and that was the first thought that came to my mind. And then there is sort of a feel here of cerebellar, isn't there? Decreased dexterity in the hands, decreased difficulty walking, and then no cerebellar or weakness reported, and then some difficulty with talking. Did you say, Maria, as well? Which does suggest perhaps a cerebellar dysarthria. However, gait, as we've talked about before here, although there's so many new people here and it's so common, it bears maybe mentioning again. I see Maria smirking because she's heard all of my scripts of things that I say over and over again, but gait is falls and gait problems are very common in clinical practice, and they're hard to analyze because the gait involves essentially all of the functions of the nervous system. So you need your strength, you need your sensation, your proprioception, you need your coordination, you need your balance, so you need your vestibular system, you need your vision, and you need higher order areas such as in the basal ganglia that initiate and pattern the gait. So a patient with a gait disorder could have difficulty with their gait just from pain and orthopedic issues. They could have difficulty with their gait from weakness, from sensory loss, from ataxia, or from Parkinsonism, from higher level gait disorder, or from frontal gait disorder, such as the one in normal pressure hydrocephalus, which I think of as a problem sort of with the gait app, the program in the brain that coordinates all of the other functions of motor sensation coordination so that we walk normally. Or they could have a visual problem. And in real life, patients at this age generally have what we refer to as multifactorial gait disorder, because by that age, they have a little neuropathy, they have a little lumbar spine disease, they have a little cervical spine disease, a little visual loss. Maybe they have a little bit of Parkinsonism, even if they don't have Parkinson's disease. And they have a whole pie chart of issues affecting their gait, maybe some orthopedic issues as well. And we're trying to figure out, is there one major piece of the pie that's explaining enough of the story that reversing it would help? Or are they all small pieces, all sort of irreversible chronic problems or degenerative or otherwise, where we want to give the patient physical therapy and gait aids, but maybe nothing intervenable? Or if we found cervical or lumbar spine disease on imaging, is that how much of a piece of the pie is that to know whether it's worth the patient's risk of intervening, or whether their neuropathy or their Parkinsonism is really the main explanation, and messing around with surgery of the cervical or lumbar spine is not going to help, and could even make things worse, in addition to the potential morbidity of the surgery. So, so this patient could have a long-standing cerebellar problem. Probably the most common, well, let me ask you, Andrea or Sridhara, what would be the most common reason that someone at this age could have this slowly progressive course of gait dysfunction now involving the hands? Let's say the speech wasn't involved. What would be sort of a chronic, mundane, common, mundane by which I mean every day, not to diminish its importance, but something that's very common that would cause a gait disorder in this progression in this age group?
Andrea, you want to go first?
My first thought is maybe Parkinson's would be something that would, well, I don't know if it would be considered mundane.
Yeah,
but
yeah. When I mean
it's
mundane, I mean
relatively
something
common.
common. Yeah, I don't mean to diminish its importance by using the term that way. Yeah, Parkinson's is common. Is it the most common thing? It's probably, I think, something like, don't quote me on this, but 1% of people over a certain age. It's a pretty common. Am I saying that right? Someone can fact check me. But I think it's a pretty common disease once we're over 70. But maybe not the most common of just sort of, and we would probably see rigidity, tremor, et cetera. I guess I mean sort of an isolated gait disorder. There are many possible answers here. What were you
Another
thinking,
one
Sridhara? First thing that comes
to mind is degenerative disc disease
Yeah.
affecting the cervical spine.
Yeah,
Yeah.
Extremely
think-
common.
yeah, I think that's right. Yeah, I would say someone with, usually a more subacute rather than chronic course in this age group, with sort of gait is getting worse, hands are getting worse. You might think of cervical degenerative disease causing myelopathy. Neuropathy would also be common, and Parkinson's is probably up there as well, and probably in real life, all of these together. So what here pulls us away from that? Well, the really long course, although spinal disease does evolve over a long course and for whatever reason tends to then present subacutely when things must hit a tipping point in the spinal canal. But the difficulty speaking would pull us away from that, as well as the complete lack of sensory abnormalities. Usually patients with cervical spine disease is going to affect the dorsal column, so they will report some numbness, tingling, et cetera. But maybe if the weakness is so prominent, they wouldn't notice it. So those are probably be the things that are coming to mind. Common things being common in real life, probably we'd be thinking of all kinds of combinations of cervical spine disease, lumbar spine disease, peripheral neuropathy, and or some Parkinsonism, though we're not hearing the other features of Parkinsonism here. But in morning report, we might be thinking about different things, although sometimes the surprise in morning report is the presentation of something common, presenting in an uncommon way. But my intuition also went towards the cerebellum, as Andreas did. Sridhara, where did your intuition go with just this small aliquot of information?
Yeah, my intuition, I mean, when I heard the difficulty speaking, it kind of took me to the cerebellum. When I think of sensory ataxia versus cerebellar ataxia, one of the biggest things you hear in the history is that dysarthria. So, that took me to the cerebellum. One thing I'll say, which you learn with clinical practice, is genetic conditions can present in someone who's in their 50s, and they can also have a slow progressive course even without a family history, just because of such a variable penetrance. So I would also think of genetic causes on top of neurodegenerative or structural causes in someone like this. And then the other thing is the showering. What we notice in the history is whenever someone says that they are much worse with their eyes closed than when they are with their eyes open. Like whenever they splash water on their face or whenever they stand in a shower, that's a clue that maybe there is a component of sensory ataxia more than cerebellar, because cerebellar, it can be it get worse with eye closure, but not as much as sensory ataxia does. So
Yeah.
those are the things that come to mind.
Excellent point. Yeah, I think the speech here. So before we heard about the speech, right, this could still be motor, sensory, or coordination. The speech, you can get motor speech problems, so that is possible. And as you said, hearing the history, sometimes we hear dysarthria, we might ask the patient, your speech, if I'm not wrong, sounds a little slurred to me. Is it slurred? And already in the history, you're hearing, there's some slurred speech here, and maybe getting a sense of what type of dysarthria that is, but we'll save that for the exam. But right, the showering, hard to know if that's just an issue of whatever the underlying overarching motor or coordination problem is. But yeah, one of my mentors, one of the great teachers of neurology who unfortunately just passed away a few weeks ago, Marty Samuels, used to call the shower the Romberg machine because it's slippery, your eyes are closed, it's dim, and he used to have a whole little story he would tell about bathroom neurology, about how you Valsalva on the toilet, open your PFO, and you can send a clot across, how you can then go into the shower and have a Romberg if you have a sensory problem, and then you can fall and get a subdural. He had a whole sort of little script of all the bad neurological things that can happen in the bathroom. But the shower sign, he, as you did, Sridhara, associated with Rombergism, or this loss of proprioception from the peripheral nerve large fibers, the dorsal root ganglia, dorsal roots, or dorsal columns. So maybe this patient's not reporting sensory, but it can be. And then, yeah, this very long, very indolent course, although we think of degenerative spine disease as occurring over a long time, at least in my experience, patients tend to present with some worsening over months, when finally brings them to care, and a problem that's been there for a long time, and a very kind of indolent, symmetric, seemingly system specific, probably we're all feeling cerebellum, though we haven't proven it yet on the exam, but could still be motor here. Would make you think of maybe more a degenerative or degenerative genetic cause. And that was on my mind as well. And it's an interesting point, as you mentioned, that we think of genetic diseases presenting in childhood, but for whatever reason, we do see genetic diseases presenting in older age, sometimes unmasked by a medication. For example, we've seen genetic myopathies, muscle disease, not that I'm saying this patient has that, but genetic myopathies that are unmasked at a later age because a patient gets a medication that's toxic to the muscles, like a statin, and people attribute the myopathy to the statin, but it's actually, there's been an underlying subtle muscle disease which sort of gets decompensated by something we do iatrogenically, or just these things are so slow that they present very late. Should we do this now or wait and make sure we're really on the cerebellum? Well, since we're all thinking cerebellum, and you were thinking of degenerative and genetic causes, Andrea and Sridhara, anything on your mind in particular that could present in this way?
Go ahead, Andrea.
Was there any genetic cause on your mind, Sridhara?
Oh, yeah, Fragile X tremor ataxia syndrome is one, where there's usually a family history of chronic static encephalopathy or cryptorchidism, and then the grandparents or might have this tremor ataxia Parkinsonian type of syndrome. Spinocerebellar ataxia is another one, and Friedreich's ataxia. Those are the ones that come to mind.
Yeah, excellent. Well, before I comment on that, Andrea, any that you had in mind, degenerative or genetic conditions of the cerebellum?
I was thinking of spinocerebellar ataxias as well, or like a vascular event affecting the cerebellum. Those were my first thoughts. Now, in terms of genetic causes, I was also thinking more like myositis or other type of muscular disorder as well that could explain the weakness.
Yeah, excellent. Yeah, so genetic ataxia is not common, but they're out there. So there's spinocerebellar ataxias. There's a whole list. I certainly don't know all of them, but primary cerebellar degenerative disorder. These patients, generally, we will see on exam if this patient has nystagmus, cerebellar dysarthria, symmetric incoordination, and then many of these have a particular regional distribution, a particular part of the world. For example, in Boston, we saw not a lot, but a few. SCA3, because that's the gene is in the Azores, which is an island off of Portugal, and there's a big Azorean population in Boston. So we saw one or two of these patients who lived in Boston. So there's the spinocerebellar ataxias. You mentioned Fragile X associated tremor ataxia syndrome. That's very rare. I've seen one case, about Fragile X syndrome, which is a repeat disorder causing impairments in intellectual development. And as you said, I believe some gonadal abnormalities as well. And it's not the patient who gets that, but it's their grandparent who has a certain number of repeats, but not enough to get Fragile X. And they develop late in life an ataxic syndrome with a prominent tremor. This patient's not reporting the tremor, and they have a very unique MRI signature of white matter lesions beginning in the pons and sort of curving in to the white matter of the cerebellum. I've seen one case of that in my last week of residency with a cerebellar specialist, Dr. Jeremy Schmamann in Boston, who sees all the most complex cerebellar cases probably in the country, or many come from all over the world to see him. And he showed me all of these cases in that clinic of things I had never even heard of. And then degenerative in this age, a primary degenerative, non-genetic or not genetic, at least we don't understand if there's a genetic component, would be multiple systems atrophy, one of the Parkinson's plus syndromes, which typically presents with autonomic dysfunction, but there's MSAP, where those patients also have Parkinsonism, and there's MSAC, where they have cerebellar dysfunction, but we would expect autonomic dysfunction as well. Okay, let's hear a little more information, Maria. So all of us are thinking about the cerebellum, correctly or incorrectly, we're about to find out, but somehow all three of us have been drawn in that direction, from clumsiness, probably hard to escape, and then this progression in the legs and arms, and then the difficulty speaking probably anchoring us there. We know we're above the spinal cord now, and then the time course making us wonder about a degenerative or genetic cause. Okay, so we might want to wonder in particular about the family history here, although there can be spontaneous germline mutations with these genetic diseases and no family history. Okay, Maria, tell us about the southwest corner here.
All right, so the southwest corner has a couple of things. The past medical history is relevant only for hypertension, and she does also have degenerative disc disease. She's never had any surgery. Her medications include labetalol and atorvastatin. Her family history, she reports that she has multiple family members who have needed the use of wheelchairs. Notably, her great-grandnephew, who is 5 years old, is now using a wheelchair. And on further interrogation, she reports that her grandfather was possibly affected, as he was also very clumsy and used a walker. For social history, she's a retired teacher, and she previously smoked marijuana on a daily basis, but stopped 5 years ago. I don't know if you want to stop there.
We'll stop there for a second. I see everyone smiling. So why is everyone smiling? Andrea and Sridhar, what here is the most significant? The labetalol? No, just kidding.
Go ahead, Andrea.
Obviously the hereditary neurological disorder suspicion. I think that's why everyone was laughing. And going back to the initial suspicion that we had on spinocerebellar ataxia, I guess this kind of makes us think more in that direction. And that's especially the progressiveness and the poor coordination, all the difficulty walking, the clumsiness. Now, it also kind of makes us wonder about other things, given the strong family history. Another disorder I could think of is some sort of like a hereditary spastic disorder. Could make me think of that, like could that also affect balance and coordination? But I don't know if you would present with this picture. This to me still sounds more like a spinocerebellar ataxia.
Yeah, brilliant. Yeah, it's a great point. So obviously the family history, people are smiling because this was anticipated by both of your brilliant discussion here, that could this be a genetic condition even presenting in old age? Both of you mentioned that even before we saw this family history, which of course now all but confirms that, although we would always have to be careful that we don't anchor, and this patient could have something different or could have the same thing but something else intervenable. Maybe they have this condition in a milder form, but they have a superimposed cervical stenosis or neuropathy that we could treat, although, gee, it's sure hard for us to pull away from such a prominent family history here. And Excellent. And you mentioned if we're thinking about familial conditions that could affect gait, we could also think about hereditary spastic paraplegia, of which there are again multiple subtypes. And I believe, if I'm not mistaken, there is, I think it's like simple HSP and complex HSP, or I forget what the technical names are, where the hereditary spastic paraplegia is presumably degeneration of the motor pathways in the cord that selectively affects the legs. That's the paraplegia part, and they develop a spastic paraplegia. But the plus or complex, or I forget what the correct terminology is, they can have other pathways affected, and then maybe there are some, I don't know these very well since they're very uncommon, could also have some associated cerebellar findings. I don't know the answer to that. So if there's spasticity, we'd say, well, wait a second, you shouldn't get that with the cerebellum. Actually, you can get slight decrease in tone with the cerebellum. We don't think of it as directly controlling the motor pathways, but there's a beautiful paper that Dr. Marty Samuels, who I mentioned, used to send around from Gordon Holmes, called The Cerebellum of Man. And it's this huge 70-something page paper from many generations ago when people were first sort of making sense of the correlation of the physical exam and what was known from animal studies and pathology, and talks about a lot of these interesting cerebellar findings. And the way to assess the diminished tone, what Marty used to have people do is stand and swing and let their arms swing back and forth. And if you do that, your arms swing sort of normally to some extent, in that patients with cerebellar disease, he would show sort of had a little bit more swing to their arms from slightly decreased tone in cerebellar disease, uncommonly known finding as compared to ataxia. What do we make of the fact that, well, there's multiple family members? Are you able to tell us, Maria, are they all of one sex or both sexes affected?
Yeah, I totally forgot, but in Russia, if you like go into the next slide, there's a family tree for people to see it.
Oh, wow. Because you mentioned nephew. So everyone with the red is affected?
Yeah, everyone with the red is affected, and our patient is the one with the arrow.
Our patient is the one with the arrow. So women are circles and men are squares. Yeah. Okay, so we have women and men. Just wondering about X-link, which doesn't seem to be the case here. And then okay, so just looking at this, sorry, I'm excited and thinking out loud and not giving you the opportunity to think out loud. So just looking at this, what type of inheritance pattern do you think we're seeing here?
So
I
if
think
it were
people didn't-
autosomal dominant, oh, go ahead, Andrew.
No, sorry, go ahead.
So if it were autosomal dominant, you would expect to see more people than what we are seeing. And so it does look like it's autosomal recessive. The one thing that I have, I run into a problem with X-linked is X-linked conditions. It depends on, like, women can have manifestations depending on the degree of lionization. Like if they have one abnormal X chromosome and that remains active, and the normal X chromosome becomes inactive in more tissues or something like that. It depends on that. So, but yeah, this looks recessive too.
Yeah, you can get X linkage, as you said. You can still affect women if there's the selective inactivation, but there's so many women affected here that would seem maybe a little bit less likely. And then dominant or recessive, I don't really think about these things too much as an adult neurologist, so I'm still processing it. Do you know, Sridhara or Andrea, from looking at this?
I'm sorry, what was the question?
Oh, do you think this is dominant or recessive?
Well, I think because it does not skip generations, to me, it still makes me think of autosomal dominant inheritance. I don't think that it necessarily needs to affect like 50% of the siblings in that big family over there. But given that it doesn't skip generations, that's my first thought.
Yeah, excellent. I don't think about this stuff very often, so I will defer to your expertise there. Okay, so we have an inherited disease. That's probably enough to get us moving here. And then the moment we've been waiting for, the physical examination to see if all of our intuitions about the cerebellum are correct. So if this is a cerebellar disease, we've talked about some of this. Andrea, Sridhara, what would we expect to see on examination? What would be some prominent signs that would confirm for us that we are indeed in the cerebellum?
So what I would expect to see is a central type of nystagmus, um, and a scanning type of speech, and then both truncal and extremity ataxia and incoordination. That's kind of what I would anticipate to see.
Yeah.
Um, and then depending on what genetic form it is, you might see additional features, which are helpful in a clue to diagnosis.
Yeah, excellent. So severe cerebellar disease, you're almost always going to see nystagmus, no matter the etiology, and it should be of a central pattern, meaning that it will be direction changing. So left beating and left gaze, right beating and right gaze, up beating and up gaze, up down beating and down gaze. We don't have time to go through all of that today, but I think the last podcast we ran was a dizziness one where we went through all of those things a month or so ago. And we can see limb ataxia if the hemispheres are affected on finger, nose, and on finger, nose, and heel shin. We can see dysdiadochokinesia with alternating hand movements. Is there a name for that? What am I? Alternating hand movements to look for dysdiadochokinesia. If it's more central, midline, vermian, cerebellar midline structures, then we would see gait more affected without the limbs, or it could be pan-cerebellar, and we could see all of those. And then dysarthria is common with cerebellar disease. It's described as scanning speech, scanning dysarthria. I often hear this. How do you interpret or explain scanning speech, Sridhara, to your residents and students?
Sounds like you're drunk, if I had to put it in a certain way.
Sounds like drunken speech, because acute alcohol consumption causes affects the cerebellum. Yeah, so people look, and patients may say, my friends keep asking if I'm drunk. They say I sound drunk. They say I look drunk. I'm not sure I've ever found what scanning actually referred to. I think, I could be wrong, sort of like scanning on the radio dial, though nobody has dials for radios anymore. Maybe Sridhara and I remember these, but many people are used to just clicking buttons. But that if you if you have your volume knob on your radio and you're kind of turning it up and down at random, the speech kind of really sounds like it sounds like ataxia. It's sort of jumping all over the place in terms of volume, which is a different pattern than you can see with other speech disorders. Okay. And you might say, and we should see normal strength, which we should, although if the patient's very ataxic, it can be hard for them to assess because they're having trouble controlling the limb. And people would think they should have normal reflexes, although, again, in this extraordinary Gordon Holmes article from many decades ago, I don't know the exact year, but we can look at that, and I can send it to anyone who's interested. You can get what are called pendular reflexes in cerebellar disease, although it's a sort of subtle finding. Okay, so what did you find on that physical exam, Maria?
So the patient's in the exam room. She's in a wheelchair. She's been drifting to the left, and she's needed help to be repositioned in a neutral position. For the neuro exam, her mental status, she was alert, oriented to self, time, place, situation. No impairment in recent or late memory. The language had adequate comprehension, could name objects, named over 30 different fruits and vegetables in a minute, could repeat. However, the speech was slow, and she had an unusual separation of syllables with variable intonation. For cranial nerves, the pupils were equal and reactive to light and accommodation. All external ocular movements were intact. There was no nystagmus seen. Saccadic movement seemed a bit slow. No sensory abnormalities in the face, no facial asymmetry. Uvula was midline, and tongue protrusion was also midline. For the motor part, muscle bulk was reduced in all four extremities. There was slight spasticity noted in all four extremities as well. All muscle groups had a 3 out of 5 strength, and she had no pronator drift. Well, it was hard to test, but the reflexes, the triceps, biceps, radialis, and patellar were 2+, symmetric. Just the Achilles was 1+, well, 1 bilaterally. The Babinski was downgoing and Hoffman was negative. For the sensory, she had decreased sensation of light touch and pinprick in lower extremities. from the foot to approximately the mid-shin, and otherwise it was normal. For the cerebellar part, in finger-to-nose testing, there seemed to be side-to-side movements as the patient approached the target. She frequently, I lost it, I'm sorry. She frequently would overshoot and miss the finger. She had slowing down the movement or closing the eyes did not modify this. She had difficulty alternating pronation and supination of the hands. The action also seemed fragmented. This was also seen with successive touching of each finger to the thumb. In heel to shin, there was also fragmentation of movement, frequently separating the heel from the leg. And unfortunately, gait and Romberg were not assessed.
Okay. Well, you were saying that, I remembered there is a name for this, rapid alternating movements, but I don't check it that often. That's why the name was not coming immediately to mind. Okay. Andrea, what do you think of this physical exam?
Okay, I'll try to reduce my anchoring bias here, but I'm still thinking of spinocerebellar ataxia even more. First, the point that she's wheelchair bound makes me think of the severe progression that is significantly affecting her mobility. The normal mental status, well, it seems like her cognitive function is preserved, although some slowing, which is probably just age-related cognitive decline. Now the slow speech with the unusual separation of syllables, I think that was people were saying in the chat, they were describing that as the scanning speech, which kind of goes with the idea of dysarthria. Now the reduced muscle bulk, I think it could be either because of the decreased use of the muscles or due to weakness, but I think it's probably not using the muscles more. And the reduced strength, I think, could also be weakness or indicating a degree of upper motor neuron involvement. The other thing that let me read over here. Oh, the decreased sensation to light touch and coordination. I think that also kind of goes along with the spinocerebellar ataxia. And as you were mentioning, that it could, if it's truncal or not, it could. I also kind of point on where specifically in the cerebellum it could be affected. So those are my first thoughts.
Yeah, excellent. Clearly the cerebellar exam is very revealing here. There is dysmetria, ataxia, dysdiadochokinesia. Maria beautifully explained or described the sort of fractionation of the movement and tremulous nature. It's an intention tremor. So you might see someone with a physiologic tremor or action tremor or drug-related tremor, or a physiologic tremor or essential tremor or drug-related tremor. The tremor comes out with action, but the movement is still precise. That's an action tremor, but not an intention tremor. And then intention tremor is a subset of action tremor in cerebellar conditions where, as the patient approaches the target, the ataxia or the tremor gets worse as a result of the ataxia. And then there's overshoot. So some people do this finger chase test where they put their finger up and tell the patient to follow it like a mirror. You move quickly and they're supposed to follow you. And with cerebellar disease, they'll overshoot and bounce back. I find this is a little hard for patients to do and to interpret. The one I like, I don't remember where I learned this, is to have the patient draw a very sharp square in the air with 4 lines. And with ataxia, they overshoot each corner. And it's, to me, a little more obvious than saying, chase me. They kind of always, in my experience, are a little bit off, but it's a little confusing. In this case, I'm sure you don't even need to do that, seeing how impaired the patient's coordination was. And so what doesn't fit with cerebellum here, Andrea teased this apart beautifully. One is that there's no nystagmus with cerebellar disease. This prominent, you would expect nystagmus, unless it was very subtle and just not noticed, or somehow the flocculonodular portion of the cerebellum involved in vestibular function is spared in whatever condition this is. The weakness, as you said, should not be from cerebellar disease, but you very astutely mentioned if this patient has been in a wheelchair for many years and is not moving around very much, could have deconditioning, atrophy, disuse atrophy, and deconditioning. Normally that's going to be more proximal, but if the patient's really not moving around at all, and with this degree of incoordination, probably would not be able to eat or drink without risking spilling things or injuring themselves. Maybe they really aren't using their muscles much at all. And the fact that the reflexes are normal, showing us that there's unlikely to be sort of a primary motor problem in the central nervous system or the peripheral nervous system. It doesn't exclude a muscle problem where the reflexes would remain intact until the muscles are too weak to generate them, which isn't the case here. Then there is this sort of length-dependent sensory loss. I don't think we heard vibration. Was vibration done or okay, Maria, or we just know light touch? And
Yeah, it was just light touch and pinprick was impaired. Vibration, proprioception, temperature was normal.
we're normal. Okay, so we have a little bit of length-dependent sensory loss in either small fibers of the nerves or anterolateral tracts, and whether that is, as you said, Andrea, the part of the spinocerebellar, or whether this patient with age has, from some other reason, not yet diagnosed diabetes or just idiopathic age-related length-dependent neuropathy contributing. So as you can see, I was also anchored on the cerebellum and tossing away the things that don't fit or explaining them away, although that can be a dangerous exercise. Should anything give us, we know the cerebellum is involved, and the question is, are there other things involved? There's probably a little bit of a neuropathy here. And then the weakness is maybe, is again, not cerebellar. We're sort of attributing that to a sequela of chronic cerebellar disease causing decreased motor activity and movement in general, leading to disuse and deconditioning. However, maybe we'll find out that we should have tried to explain that more. But cerebellum and muscle as a Venn diagram, that would be hard for me to put together. There is, I think, is it POLG genes? I think a mitochondrial gene. A resident just showed me a long-standing degenerative cerebellar ataxia that they diagnosed with a genetic panel, and a POLG, P-O-L-G mutation came back, which I believe, if I'm not mistaken, is either a mitochondrial gene or a nuclear mitochondrial gene. And so mitochondrial conditions can also have all kinds of other elements to them. Okay, so is there anything else this could be but familial genetic? With that family history, it doesn't seem like it. Let's just, for the sake of learning for a moment, what other cerebellar conditions could there be had we not gotten this family history? And we can, take some poetic license with the time course as well. So let's say this patient said, it's been going on for some time. Well, months, years, I don't know, months, years, something, yeah, not 20 years probably, but let's say months of this same syndrome. Patient presents this way and it's been going on for months. What could we think about? Just categories of illness. So we take out the degenerative and genetic, months of a symmetric pancerebellar syndrome.
So that would leave autoimmune or paraneoplastic high on the differential.
Yeah, you see where the neurologist goes immediately, right? So when we hear about symmetric cerebellar dysfunction evolving over months, especially if the imaging is normal, we worry in this age group about paraneoplastic conditions in women with ovarian or breast, and men, young men in particular, but older men, I think it's bimodal testicular cancer with anti-Yo, anti-Re, or anti-Ma-Ta antibodies, although there are others. Very important diagnosis to be aware of. Other immune non-paraneoplastic cerebellar you would think of, there's a gluten-associated ataxia. Patients don't always have all the symptoms of celiac disease. It's a bit of a controversial entity. Other antibody-mediated but non-paraneoplastic, anti-GAD, GAD can do this, although it's very common to get a false positive GAD of low titer. And there's a long list that I don't know all of them of cerebellar antibody-mediated autoimmune or paraneoplastic cerebellar. Others, Andrea or Sridhara?
Vitamin E deficiency, B12, and then nitric oxide, whippets, which seem to be on the rise.
Yeah.
Again, they can cause a myeloneuropathy and they can also cause ataxia.
Yeah. So yeah, if it was a non-cerebellar ataxia, sensory ataxia, yeah, we'd be wondering about B12 deficiency, or as you said, with whippets and nitrous oxide intoxication, patients have a functional B12 deficiency as a result, can get the same syndrome of subacute combined degeneration. Vitamin E deficiency is reported. I believe it usually needs a gene as well, where you get vitamin E associated cerebellar ataxia from not either absorbing or processing the vitamin E. There's the variant of JC virus granule cell neuronopathy. Is that what it's called? It's a pan-cerebellar disease from JC virus. Granule cell neuronopathy. Is that right, Sridhar? Do you know what I'm referring to? Or grant?
Yeah, it causes like one layer of the cerebellum to just be like to just be destroyed, and it causes presents as ataxia.
Is that the name of it?
Usually
Granule cell neuronopathy. Is that right?
I don't remember the term of
Yeah.
it's I think like cerebellum predominant JC virus.
Yeah.
Yeah,
I
there's just
think that-
atrophy.
Yeah, it's atrophy without the white matter lesions, which it's granule cell. Anyway, someone can check me that has a name. It's not, I've never seen it, but I've seen it reported.
I mean,
Yeah.
just seeing this case, one thing that comes to mind, like that's been very useful for me, is if I see ataxia and I see a neuropathy on top of that, my mind always goes to recessive ataxias. Whereas if I see spasticity or hyperreflexia, it goes to like dominant ataxias, and that's served me as a useful like clinical anchor in the past.
Interesting.
But
yeah.
it's hard because there's just such an expanding list, and the recessive ataxias are also growing.
Yeah. Yeah, I'm not sure any of us could say which genetic ataxia this is. Probably this patient would get neuroimaging to make sure we're not missing, I don't know what mass would go this slowly or other cerebellar process aside from degeneration. But again, in the subacute time course, we might also think of not just paraneoplastic, but neoplasm. Primary neoplasms in the brain, usually supratentorial in adults, infratentorial in children, but metastases can be super infratentorial. What would you expect if this is a genetic ataxia? What would you expect to see on the neuroimaging?
Andrea?
So I would first expect to see cerebellar atrophy. So that would be my first thought to see in both the T1 and the T2 images. And given the gait imbalance, maybe like we would also see more pronounced in like the middle of the cerebellum. So we may see like specific patterns of atrophy. I think, let's see, maybe some white matter changes given their age, and they are also hypertensive. And well, I wouldn't know if they would necessarily be associated with their condition right now, but if they're located near the cerebellum, that would be suspicious. I would not expect to see any acute findings. They would be more incidental, so suggesting something else. Maybe I know sometimes these syndromes also present with like brainstem atrophy around the pons or the medulla, but I don't know how specific those findings are. But overall, that's what I would expect mostly, like cerebellar atrophy and like non-specific white matter hyperintensities.
Yeah, brilliant. So from the genetic ataxia standpoint, yeah, we would expect cerebellar ataxia. Sometimes that's when it's midline or Vermean, atrophy. Midline or Vermean atrophy. The best sequence to look at is when we don't usually use, we're often looking at the axials and coronals, but the sagittal view right at the midline, you can see that the folia of the cerebellum, particularly superiorly, are particularly prominent, whereas they don't look that way normally, but you have to have seen a lot of normal scans to pick that up. And then very astute of you as a white matter disease expert to say probably at this age with hypertension, this patient also has chronic microvascular disease and will have some non-specific white matter changes, which should not be attributed to the cause, or her syndrome should not be attributed to those lesions, and they're very common and incidental. Yeah, so this patient probably got imaging, probably does have cerebellar atrophy unless we're in for some major twists and turns, and I've budgeted our time entirely inappropriately. But to make the diagnosis here, we would need genetic testing. And while you would ideally say, well, where is this patient from? And let's see some other features, and let's send a particular gene. Now with the decreased cost of whole exome sequencing, it's often more cost effective and efficient and just honest about how easy it might be or not to be able to tell SCA 17 from SCA 13 or something like this, unless someone else in the family has already been tested, to just send whole exome sequencing for causative genetic cerebellar disease, as my colleague, one of our residents did, and found this POLG mutation. I wouldn't have even known to send that if I had to send one gene after another. So I suspect this patient got an MRI and that it was okay, unless Maria has a big surprise for us at the end, that the patient got genetic testing. And I guess or looking at an SCA. And I would guess with the nephew being the only young person to be already in a wheelchair at that age, that this is a repeat trinucleotide repeat disorder. And I don't know which of the SCAs are dominant, recessive. I think they're all actually I don't
SCAs
know.
are they're
Recessive, right? Are they?
because Friedreich's ataxia, telangiectasia, and canvas are all recessive ataxias. Hereditary
And the
spastic
SCAs are dominant?
paraplegia, SCA, and they're all dominant.
They are dominant. Okay, so they're dominant. And then are some of them nucleotide repeats? I presume some of them
Yeah,
are.
yeah. Like,
Not all of
and
them.
the nucleotide repeats, the only problem is whole exome will miss them. So
Ah.
that's like a pitfall with whole exome sequencing.
That's a good point. Yeah, so that's a great point. Yeah, that's a great point.
I've been burned by that before. That's how you learn.
Yeah,
You live
yeah.
and you learn.
The counter burn or the non-burn I've had is I thought I saw a patient with hereditary spastic paraplegia. Do I have a second? Not really, but I'll take it anyway. Because it was a fascinating case patient who presented in his 30s or 40s with progressive spastic paraparesis. Actually wasn't that weak, but very spastic, every upper motor neuron sign. And he had multiple normal MRIs of his spine, had one MRI of his brain that showed a small white matter lesion in the center of the splenium of the corpus callosum, had been referred to the MS center, and they said, this is not multiple sclerosis, sent him to general neurology. And I saw him and I said, well, everyone's already done all the work. This guy has had this thing going on for years. He has no explanatory lesion on his imaging, and his labs had all been normal. This must be a genetic thing. And I was asking a colleague, had just been starting out as an attending, which hereditary spastic paraplegia gene do you think this is? There's no family history. And they said, don't waste your time, do whole exome sequencing. And the patient actually had adrenomyeloneuropathy, a variant of adrenoleukodystrophy that affects the spinal cord predominantly. So it was a case where I knew that it was a genetic paraplegia, but the list of all the things that can cause that is pages and pages long. And by doing whole exome sequencing, you can just tell you this is the abnormal gene. You say, oh, I wouldn't have even known to send it. But good point that certain types of mutations might not come up there. So there may be a targeted genetic ataxia panel that you would send somewhere that would know the best molecular biology techniques to assess this. Okay, Maria, so tell me that we have 7 more aliquots and we all went in the wrong direction here, or give us the final aliquots and the final diagnosis.
No, just one more aliquot. The only imaging that was available was actually from 15 years prior to her presentation. She had, at the beginning of her experiencing these symptoms, she consulted a lot of doctors who couldn't really see anything in the physical exam, and she was very, I think, frustrated with that. So she only got one MRI, and she said she was never going to do any more testing again. That MRI said she had, like, it was only reported mild cerebellar atrophy. And she was just coming back, not because she wanted any more testing, but she wanted only the genetic testing, now that multiple family members had been affected. So there was an ataxia panel that was sent, and then allele came back with 39 repeats of the ATXN7 gene, which is, should I say it? I think you said a
Ataxia, telangiectasia?
No, it's actually spinocerebellar ataxia
Oh,
type.
wow.
That's the gene.
Which number is it, just for fun?
7.
7. So I learned a couple of things from
Teach us. Yeah.
Yeah, spinocerebellar ataxia type 7 is actually one of the rarest ones. If you want to have some sort of association, it presents with retinitis pigmentosa, or retinal, macular degeneration, retinal disease. But there's 2 different phenotypes depending on the types of alleles she had. So if it's less than 50 or something around that number of alleles, it presents very slowly. Elderly patients, they tend to progress very, very slowly, and they don't usually, something that you were saying, Aaron, that you expected the nystagmus, you expected more ocular findings. Actually, if they have less than 50 alleles, that can be preserved until later in the disease. So it was hypothesized that she'll eventually start having those findings, but not before, because of the type of phenotype she was presenting. When it's presenting in younger ages, so pediatric ages, They usually present very suddenly, a lot of cerebellar dysfunction, and they present with the retinal abnormalities as well. So it might be even picked up by an ophthalmologist instead of a neurologist. But yeah, that's some of the things I learned about SCA7. And overall, of all of the SCAs, I think I think retrospectively, it was easy to figure out. It was cerebellar in nature, and with the hereditary disease, it was going to be like a hereditary cerebellar process. But I think reading through the SCAs, I think there's so many like heterogeneous findings. You can actually have like peripheral neuropathy in some sort of findings. Some report, hyperreflexia, spasticity, Babinski. Some report, like atrophy, fasciculations, hyperreflexia. Some report like autonomic dysfunction. So I think it's super variable. And because of the differences in alleles, like in the phenotypes, you can miss like the cerebellar part of it for such a long time. If it's like very slowly presenting as this one. So I think retrospectively it was easy to say, but talking with this patient and seeing all of like the primary care notes and things like that, I realized that, if she would have presented 5 years into the disease, I definitely would have missed it. Everybody would have missed it. And yeah, I think that's what I learned.
Yeah, brilliant. Thanks for teaching us. Yeah, we all knew of the spinocerebellar ataxias, but knowing one from the other, as I mentioned, one of the world experts, Jeremy Schmaumann, who I got to learn from as a resident, he would come to these conferences and say, well, in SCA7, they have this, SCA11, they have this, but in 5, 9, and 14, it was just extraordinary to hear someone know all of these. And I thought, wow, if I'm a neurologist, will I know all of these one day? And the answer is no, unless you have really are seeing them all the time and becoming familiar with them, but to know that they're there and to look for them, and Sridar's excellent point that they might be missed on whole exome sequencing is important. Maria, you sort of alluded to this, but what was ultimately made of the reduced muscle bulk and weakness? Is that part of the disease or just secondary to being in a wheelchair and not moving very much?
It actually could be part of the disease in some present, like there's very few, so some case reports do report that very early on, so it wouldn't be explained by the wheelchair. But I think in this particular case, she had been in the wheelchair for 5 years. She was not in physical therapy or occupational therapy or anything like that. So I think it was just the decompensation from the muscle bulk. But if you read case reports, I think it's very hard because a lot of the case reports do have very particular findings that don't go into like the general picture, and there's like no sort of explanation. And what I've read about SCAs is that there are so many different phenotypes that and there are very few cases reported, or like there's not like a very big case series except for SCA3, that it's hard to like actually nitpick on these types of findings.
And the patients that do have, you mentioned fasciculations weakness, is there thought to be a concurrent neuropathy or muscle disease or motor neuron or?
Neuropathy in some sort of SCAs that I read, not in this one, but other SCAs. But yeah, I didn't really look it up in much detail.
Yeah. An interesting explanation for the nystagmus, that that part of the cerebellum degenerates later in this disease.
Yeah, it was interesting because actually, if you have 36 repeats of the ATXN7, you don't get the diagnosis of spinocerebellar ataxia. So she only had 3 repeats more than what's typically, I don't say like maybe normal. So I think I had never put that much attention to the number of alleles, but in SCA7, they do report like 2 different phenotypes, and the less phenotypes you have, the less like ocular manifestations you have from like the retinal disease and like the cerebellar ocular dysfunctions. Yeah.
Fantastic. And my last question for you, what part of the world was this family from? I know you've been practicing neurology in at least 3 countries over the last several months.
Yeah, this one was in the US.
This was in the US. And was the families, if you're able to say, heritage from like Western Europe or Asia or Africa or?
They were African American.
African American, yeah. And is there any regional or predisposition to this?
No, it's SCA7. It's actually been reported more in like Northern Europe. So this was also like a interesting finding. There seemed to like because of the anticipation part, what we were hypothesizing was that like the youngest member of the family was 5, and that's usually something that happens in triplet disease, that some like the grandkids may be affected even earlier than grandparents. And unfortunately, there was a lot of new or younger family members that were being tested just to see if they were going to develop this. But
I see.
what I've read is that there was no, like it's usually Northern Europe for SCA7.
Northern Europe for SCA7, fantastic. Well, thank you so much for bringing this case that allowed us to talk a lot about the cerebellum, which I'm not sure we've done here before, and talk about genetic cerebellar ataxias, which we all knew existed, but haven't gotten to really dive into one in detail, as it sounds like you did, and you've seen a disease few people in the world have seen, because this, as you said, these are uncommon in general, but each individual one is particularly uncommon. So I think given that we've run over and you've given us so many excellent teaching points, although I see many have been documented here as well to read and to follow up on when people look at this one online, I think we'll stop there for today and thank Maria for bringing us this excellent case, presented like a seasoned neurologist as always, and always a pleasure to discuss with you, Sridhara, and have your perspective as a fellow neurologist, and Andrea, your perspective as a future neurologist. And I think we're going to be doing these about monthly now, barring many inpatient blocks back to back, as I've had in the past few months and may have in the future. So thank you all so much again for your participation and for joining us, and look forward to seeing you again soon. Have a wonderful day.
Thank you, everyone.
Thank you all so much.